Hello and welcome. My name is Carol Carter and I'm the founder and CEO of Global Minded. We are about creating a capable and diverse talent pipeline to get more women, people of color, underrepresented populations into the education, employment, economic mobility, and leadership pipeline. We have an incredible opportunity today with our health equity team of leaders to launch our Courageous Conversations Catalyzing Change. And it happens to be on the day that the Nobel Prize winners were announced. And after 119 years, we still have yet to have person of African descent represented in that group. So we know how many amazing people there are that represent diverse backgrounds, and 3% women, I think, have won Nobel Prizes. So we know that our work, especially during these times of COVID, is mission critical. So we're appreciative that you joined us today. And it's my pleasure to turn this over to Dr. Monique Butler, who's leading Global Minded's health equity team. And we hope that you will be part of these Courageous Conversations monthly Catalyzing Change. Monique?
Good afternoon. Thank you so much, Carol. I really appreciate this opportunity. You know, I'll tell each of you that the future of work is diverse, it's inclusive, it is just, and it is equitable. I am Dr. Monique Butler. I'm the Chief Medical Officer here at Swedish Medical Center in Inglewood, Colorado. It's just a pleasure and an honor to be before you today with really a superstar panel. You know, these conversations are one of many. And so again, would like to welcome you to the Global Minded Courageous Conversation Catalyzing Change in Health series. And we're calling it a series because there will be many conversations. But I'll tell you, I just want to make sure that everyone is on the same page with us, with each of the panelists here, myself. We are catalyzing change based upon the ability to make change. There have been many conversations, especially during this COVID pandemic, and many of us have become very used to Zoom and to WebEx and listening and having conversations. And I'll tell you that that's very important. At first, we definitely need to put the information out there so that individuals are aware. But this particular platform is based upon tangible, action-oriented solutions to the United States health equity crisis. Our goals are pretty simple, and they are: one, to level set the problem by providing factual data information, but then most importantly, creating tangible economic solutions. We will be leveraging financial stakeholders and policymakers, really focusing on the social determinants of health and removing barriers to care. You see, we are the thought leaders, and we want to be the group of thought leaders when individuals who are policymakers want to launch programs around health equity. This will be the team that they will go to. I am a first-generation college graduate. I grew up in Michigan. And my why for health equity is because as a first-generation college graduate and the only doctor in my family, I knew that I wanted to be a doctor from a very young age, and my parents really stressed the importance of that. They stressed the importance that I, even though they had not been to college, could go to college and could make changes in the world. And so I am eager to introduce to you a panel full of individuals. But before I do that, I'm going to turn it over to Dr. Pierre Theodore so that he can introduce himself. He'll give you his why, and then he will introduce our great list of panelists. Dr. Theodore?
Thanks, Monique, and what an absolute privilege to join you today. So on behalf of 135,000 employees at Johnson & Johnson, I am thrilled to be here to discuss health equity. And in fact, the size and the breadth of our organization at J&J positioned us to the point that we have a requirement. We have a responsibility to respond to social and racial injustices, particularly as relates to healthcare. So by way of background, I'm Pierre Theodore. I am a cardiothoracic surgeon. I remain in clinical practice on the adjunct faculty at Stanford University. But I'm also Vice President of Medical Affairs at Johnson & Johnson, and I'm responsible for overcoming access barriers in low resource settings. So what is it that stands in between products and services and the vulnerable populations that could be best served by those services or products? We are very lucky to have such a panel today, and it's rare that I have this opportunity to say something of this sort, but It is great to be the least accomplished person on a panel when I look over the talented group that are here today. And so without much further ado, what I think we should do right off the bat is go around the horn, as it were, and discuss each of the members of the panel and a bit of their background before we start to dig in some specific questions around health equity. So with that in mind, Dr. Georges Benjamin, perhaps we can turn to you for an introduction, and then we'll move on to Dr. Gracia.
Sure, I'm Georges Benjamin. I'm the executive director at the American Public Health Association. I'm an internist and an emergency physician. I have worked for many years to push America to not just look at reducing health inequities, but eliminating health inequities, because we know it's possible. We know that simply trying to reduce something is not an ideal endpoint, and eliminating these health inequities at the same time by trying to achieve optimal health is absolutely what we need to do. And my why is that this is a quest that I know is achievable.
Thank you. Dr. Gracia?
Yes, thank you. Good afternoon, everyone. It's such a pleasure to be participating in this courageous conversation and to be joined with so many wonderful panelists and colleagues. My name is Nadine Gracia, and I'm the Executive Vice President and Chief Operating Officer at Trust for America's Health. We're a nonprofit, nonpartisan public health policy, research, and advocacy organization in Washington, D.C. that promotes prevention and public health. Prior to being at Trust for America's Health, I was the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at the U.S. Department of Health and Human Services. I'm a pediatrician by training, and my why stems from my family's background, really in particular my two greatest role models, who are my parents. They were both educators in Haiti and came to the United States to provide greater opportunity for our family. And because of their sacrifice and their humble beginnings in starting out with my father painting boats for $1.75 an hour and my mom as a nanny, living as a live-in nanny, I learned from them sacrifice and perseverance, and that the greatest difference I could make was being able to serve others, especially those who didn't have opportunity. And so it has been a lifelong mission and quest for me to advance health equity for the nation and to ensure that everyone has a fair and just opportunity to reach their full potential.
Thank you. Dr. McNeil-Miller, if we could turn over to you.
Good afternoon, everyone, and thank you to Global Minded for this great conversation. So I am Karen McNeil-Miller. I'm the president and CEO of the Colorado Health Foundation, located in Denver, Colorado. We are committed to bringing health in reach for those for whom it is furthest in reach. And those are Coloradans living on low income and who have traditionally had less power and privilege. And when you intersect those two lines, that puts us squarely into Black, Indigenous, and people of color communities. So I do not have a health background, but that's okay, because we know that in the equation of what goes into making a community or family its healthiest, while we certainly need access to high quality, affordable, clinical, culturally competent clinical clinicians, that accounts for so little really of what goes into making our communities healthy. And it does those social determinants. So I'm excited that we're doing this work. My why is, like as Nadine talked about, I grew up in Shirley and Solomon McNeil's household. Didn't have much of a choice about whether you had social justice as a cause. This is not now and has never been an intellectual or theoretical conversation. These are the communities I grew up in. These are my families. These are people I know. And I see every day the poor health outcomes, and health as broad as you want to take it, because of historical and systemic racism. And I'm just, alongside all of you and all of those listening, I'm sure, I'm trying to do my part as a soldier in this work.
Fantastic, thank you. And Dr. Rios? Elena's had a little bit of trouble with her connection today.
She has some technical difficulties.
Got some tech indeed. So we'll come back to her as soon as she gets on. And Samuel, maybe this is a good opportunity to turn it over to you. We can even blend directly into the work that you've done for McKinsey & Company to share with us today. So I'll turn it over to you, if I may.
A pleasure. Thanks so much. Again, such a pleasure to be here with everyone. Sam Yamoah, I'm an associate partner at McKinsey & Company, and I lead most of our work in the healthcare equity space. This is a very important topic for me, just personally, my own experiences with my family and challenges in healthcare. But I think one thing is for sure is that, investing and prioritizing healthcare is something that has a moral and economic imperative. Right? Every year, poor health takes a heavy societal and economic toll. And if we're able to make improvements and improve healthcare for all, there's significantly more we can do in terms of improving and adding lives to lives and livelihoods of folks. And I've spent most of my time also since COVID hit focusing on the impact on COVID on Black lives and livelihoods. And it extends more to most of our minority groups that have seen a direct impact. Why for me is that I strongly believe that in the US and globally, we can invest in the lives and livelihoods to improve economic impact for all. So that's why I'm excited about this topic and continue to research it. I know you had asked about a recent article we published right when COVID started in April. And, we were taking a forward-looking view. Actually, the week before we published was when most folks started to talk about the challenges and what could be coming. When we did a look back in July, we saw three things that had occurred. One is that if you were Black, you were 3.8 times, close to 4 times as compared to white peers to have died out of COVID, 3.2 times for American Indian, 2.5 times for Hispanic Latinx, 2.6 times for Pacific Islanders, and 1.5 times for Asian. And all these were driven by disparities that we believe were underlying inequities. One, socioeconomic factors. 2, just structural racism that exists. 3 is clinical health, so chronic diseases and comorbidities that impact communities of color. The 4th one is access to care and information, both from coverage, telehealth challenges, and then the 5th piece is just quality of care and experience that folks encounter day to day. So trust, provider bias, some of the language and culture challenges that impact most of folks that use our healthcare system. So if you look at that into what to reflect, if you're Black, you're 4 times as likely would have actually died as the impact of COVID-19. I think as we go through all of these analyses and see the data that's out there, we also try to pull out a few things when it comes to socioeconomic vulnerabilities, right? Because I think when you focus on the problem at hand, it is just not all about access and care. There are all these social determinants of health we talk about: housing, unemployment, incarceration, poverty, food insecurity, and also neighborhood stress that we believe are factors that needs to be addressed when it comes to the overall health of everyone in our communities, specifically people of color. And we can see that there is an exponential impact when you start to look at some of these issues by race and ethnicity. I think that said, we try to lay out 2 views of how we should address the problem. It is no longer acceptable to admire the problem, and so we pushed and challenged ourselves to come up with immediate actions that we felt public, private, and social sector leaders needed to address. So I'll touch on, the 2 aspects. One from the immediate view, which I think we've started to see some improvement there. And then the second piece is the long term. I think we laid out three main, call it opportunities or challenges. One is providing equitable access to testing and care. And so we've seen most of our government agencies, our federal, municipal, and state level starting to track and publish some of the data that's disaggregated by race. The second piece is actually training and collaboration with community health workers and partners. I strongly believe that in order to deliver care, it is about meeting people where they are. There are longtime community activists that are embedded in communities, delivering care and understand the context. And so it's very important that we can build collaboration with some of these community activists and leaders to be the first point when it comes to healthcare, and particularly pushing for faith-based organizations to be a hub for workers and residents when it comes to information dissemination. The third bucket, which we really think is important to the livelihood aspect, is employer protections and commitment to equity. I think when the pandemic started, we saw a lot of organizations quickly coming to the forefront saying, we're going to provide hazard pay and so forth. But as you know, it's been 6-7 months now. I think some people have started to roll back some of those provisions. And I think it'll be important to continue because as we know, folks, whether it's, our truck drivers delivering our food, grocery workers that are providing, making sure that we have meals on our table, they're all putting their lives and families' lives at risk when they continue to be out there helping us in the pandemic. So that is another thing to try and make sure we can focus on. I think long-term impact for different communities, it's about prioritizing and continuing to collect representative data. Testing has been one piece, deaths has been another, but there are other types of data we can collect. An example being, how much are we prioritizing in preventative care by race and ethnicity? And so just making sure that there's more we can extend beyond just COVID data. I think that the second piece is integrating what we call equity teams to mitigate disparate impact. So this is for every organization as you think through equity. How do you have a small group of people that are thinking about this day in and night, using the data that you have to deliver specific interventions to help different communities, both vulnerable and those that are, reliant on whether it's your organization or in your community. I think the third piece, we've seen a good deal happen recently. We need to see more to hold accountability, is publicly disclosing commitments. I know my organization has made a commitment of 10 actions that we're holding ourselves accountable to, both from what we're going to do internally, the ways we're going to serve our communities, and philanthropic donations as well. So continue to do that. And last but not least, living in Minneapolis, where Memorial Day started, I would say something we've all known about, but the events here, further amplified. I encourage, a piece of our, at least the article that we put forth is empowering Black-led community organizations, right? So how do we make sure we're investing and partnering with Black leaders and organizations? And you can extend it to, Hispanic leaders, East Asian leaders, to address some of the pre-existing challenges that various communities of colors face. But I'll pause there because it's a rich dialogue. Would love to hear other panelists share. But again, I will put all the materials we've published here. The headline is, COVID has amplified, it has exacerbated the challenges and systemic issues that have long plagued this country, and not anything new most of us don't know today.
Thanks, Samuel. That was perfect to sort of tee up our discussion. couple things jumped out, and the first thing you said is that we have long since, quote, admired some of these inequities that we've all observed. And I think going beyond that to no longer merely a demonstration, but think exactly what are the implementation steps are to address these inequities is key. And with that as a backdrop, we've also had Dr. Rios come to join us, and I wanted to give her a moment to introduce ourselves, and then I thought we might enter into a little bit of a question and answer session about some of the topics that you brought up during your discussion, Samuel. So Dr. Rios, maybe I could turn it over to you for an introduction of yourself.
Sure. Dr. Elena Rios.
You know what, Elena, we're still having a little,
Elena,
Elena, we're still having a audio issue. I'm wondering if you could just do it by phone, if we could hear you better.
We're going to move on, Elena, and we're going to come back once you sort out
Association
your issues. So
in Washington, D.C. And sorry, can you hear me? Need the password?
That's good.
We can, that's better. I don't know what just happened there, but yeah, better. Go ahead.
You can hear me? Okay. Anyway, as president and CEO of the National Hispanic Medical Association in Washington, D.C., we have actively had educational seminars since May, and we have chapters at the local level that are networking with their doctors, hospitals, clinics that take care of the safety net. And we're sharing information through our chapter webinars this fall. And then we'll continue the national webinars again in January. So good to be here.
fantastic. Thank you so very much. So, you know, Dr. Benjamin, Georges, and Dr. McNeil-Karen, I wonder if you could kind of kick us off a little bit on a discussion as to the truly actionable steps at the level of the community that can address inequities in healthcare, yes, but more broadly. I think, Karen, you made an important point that when you look at the social determinants of health, it is true that access to healthcare is an important factor in the determinants of health, but certainly not the major and certainly not the only. And I was wondering if we could all start to reflect on the issue of what are the specific actionable community-based steps that we think can result in a demonstrable impact in health inequity. So maybe I'll turn that over and we can kick off that discussion with you, Karen, and maybe Dr. Georges, you could pick up from there.
Sure, thank you. I want to underscore what Samuel said, that, and I'm very excited about the increased interest in the pronounced health, social, and economic disparities and inequities that happen in Black communities. And want to underscore that for people who center their work in Black communities and for people whose lives and lived experience are centered in Black communities, this is neither new nor news. I don't know that any poor person has ever uttered the word social determinants of health, but they talk about it every day and talk about it in terms of, I just can't seem to ever get ahead. I got more bills than money. No matter what I do, life is hard. I'm tired of being sick. I'm sick and tired of being sick and tired. So all of those things are not new. And I would say that one of the first steps is let's talk to those people. As much and as many degrees as we have between us and as well intended as we all are, if we don't actually ask people with whom we want to be in partnership with and in service to and for, what their experience is like and why some of these things exist, I don't think we can get very far. I don't think we recognize fully the extent to which the stress of poverty, the stress of being a minority in the United States pushes so many other things down your list. So they don't have the luxury worry about getting an annual physical. They don't have the luxury of worrying about if they and their children are flossing twice a day. So to really understand that experience that is now a major conversation, but to that community is just another Monday. So how do we help people understand what that just another Monday looks like and how we can move past that? And I am not one who says I can't wait for things to get back to normal, because normal wasn't so good for so many people in so many communities. I put some of those actions to reimagine a new normal are, let's talk to the people, let's talk to people in the community, and not, actually, let's not talk to them, let's listen to them and learn from them as our first step. And then I think there are certainly policy implications in there, both at the corporate level, at the local level, at the state level, and at the national level we could pursue.
Sure. George Benjamin, let me build on that. So, as you can imagine, I'm an ER doc, and one of those painful revelations I always talk about is that 80% about what happens to make people healthy occurs outside the doctor's office. And what that means is that we have to empower communities as we listen to them and work along with them. We have a tendency to take our plans of action to them and share it with them as though our knowledge and our wisdom is actually going to get them better. Far too often, we've gone in, as a public health person, we've gone into communities and they'll say, yeah, we understand that losing weight's important, but unless you fix my sidewalks, or in some communities, give me sidewalks, fix the lights so I can actually work, walk outside after I've done my 2 shifts, make my community safer, or fix the playground, you're not going to get me to get more physically active. Not going to happen. And so we have to understand that we have designed the system for inequities. And our goal is to remove all those barriers that we've designed to people. And many people say, well, it's just that those folks that are having problems. No, rich folks have the same problems. In really enlightened communities and countries that have a home visit for every woman who gets pregnant and delivers, they find enormous issues in the families of those newly delivered women and their families that need to be addressed. And it's not just in low-income communities. And yet we've not built a society that values pregnant women and newborns like many other nations. We build communities without sidewalks, even in well-to-do communities, and then ask ourselves why they're not as healthy as we want them to be. But if you actually go back to the root causes of most of our ill health, it's in the social determinants. And by the way, racism and discrimination clearly plays a role. Redlining for housing, the fact that we clearly don't invest in low-income schools as well as we invest in the higher income schools. We have a structure that gives the money to the schools based on property taxes. So if you devalue the homes, you're automatically going to devalue the amount of money that can go into their school system. So we have to fix those fundamental structures that we have in place, understand them, and more importantly, understand why they were put in place in the first place. Many of these things did not happen by accident. Many of these things were designed to keep people, quote unquote, in their place. And we have a lot of work to do. And then we marvel at the enormous health costs that we have to spend fixing things that never had to occur in the first place. And the COVID-19 pandemic has brought that realization into the light. And the question is, are we going to have the political will, the fortitude, and the perseverance to fix these things once and for all in our country?
There's something you mentioned I wanted to take up. I think it's critically important around political will. And in fact, these inequities, they are not by accident, right? These are a legacy of systemic issues around discrimination that are manifested in healthcare. And, for example, I want to give one specific example, and I was hoping maybe, Nadine, you could reflect on this. And I'm going to call on you, if you will, because of your background at the federal level with the DHHS. And it's that a recent memo from the White House has effectively forbidden training around critical race theory, white privilege, around systemic racism, unconscious bias. That is, it's effectively, in the short term at least, effectively ruled out that we can train on these critical issues. So if the medicine is to sort of train around systemic legacy of racism, we in some ways have an interference to be able to train around that at the federal level and on all contractors that serve the federal government. So I'm curious, is there an issue with education around social determinants of health and making sure we can train on these issues? So I would love to kind of get your thoughts about, how do we make sure not only that the individuals on this call and those joining this are actually understand the issues behind these social determinants of health, but that we can educate broadly around these underlying mechanisms.
Well, thank you. I mean, you raise a very important point, and George has talked about this, of the understanding of how and why these structures exist. And we're talking about this as far as structural drivers of health, and that some of the most important drivers of health actually are outside of health and healthcare. While health and healthcare are certainly critical components and factors, they are not the only ones. And so having that understanding and actually educating to understand those root causes really necessitates that. We have numerous studies that show that there is bias and discrimination that happens in healthcare, in education, and in multiple sectors. You can point to, for example, the unequal treatment report, which showed that race and ethnicity were predictors of quality of care, even when you controlled for numerous other factors, such as access to health insurance coverage or other factors, education level. And so in order to really be able to dismantle these inequities, it's important to have that understanding and to have that appreciation for systems that have policies embedded in them, where you can look at, even through the framework of trying to think about this as a transformation for the nation, because we are really at a point in time where, if we look at the COVID-19 pandemic, it's a transformative moment to be able to say, are we truly going to commit as a nation to ending inequities? It's really one, dispelling and dismantling this hierarchy, this false hierarchy of value based on a social construct of race. And we know that we all talk about everyone having biases, whether they're implicit or explicit biases, but there are intentional ways in which policies and systems have really benefited some and not benefited others. And I think a key part of that is understanding that we have to work across sectors. You're hearing, when we talk about social determinants of health, it's every sector, whether it's housing or education, the criminal justice system, that it really requires a multi-sectoral approach, and that we have to, as others have mentioned, really ensure that the community has a voice, that the community is empowered, that the community, that there's meaningful and authentic engagement, because for far too long, so many communities, and in particular communities of color and low-income communities, there's been a disinvestment in those communities. And so the opportunity to be and have the conditions that actually promote health are really not within reach. And so we have to understand that it's not about the individual responsibility, but it's actually about understanding the conditions that actually promote health and why those inequities exist and how we work to dismantle them, whether through policies or programs and investment in resources and actual opportunity in those communities.
Thank you. There's some work that's done by Dr. Tom Levis, who's the Dean of Public Health at Tulane University, on health inequities. And he does some interesting work where he has tried to control, particularly looking at areas in urban Baltimore, where he tries to control for income and access and education levels, and finds that many of the disparities actually tend to disappear when you control for these other factors. But there always is a residual health disparity that remains. And I wonder, for those that are perhaps coming at this from more of a medical background, the term cultural competency comes up from time to time, how the healthcare system itself interacts with marginalized populations, underserved populations, Black and brown populations. And I'm curious if the panel has any direct experience or particular thoughts about increasing the cultural competency, overcoming the way the healthcare system actually interacts with the communities directly.
Hi, this is Georgia. So the first thing you want to do is you want to make sure you get increase the number of people that look like me, and people that represent the communities in which they're providing care for. You know, we all have different life experiences. Now, granted, I grew up in an upper middle class family, and so I do not have the same life experiences that many African American individuals had who grew up in lower income communities. And I've learned through the years that I don't have all those life experiences. And so for some things, I've also had to become culturally competent in order to provide services and care. So we often think of this as, you know, a white-Black issue or a Latinx, white issue, but it's not the case. There are issues around class, life experiences, where you live, what you did, all those things play into this. And so it is a complicated way to look at it. But at the end of the day, we know very clearly that wealth and health strongly align. If you look at the work of Michael Monmouth in Britain, where he looks at race as a component of his work, but a strong component of his work is class. It's economic inequality. Mm-hmm. And simply having an equal paycheck doesn't give you equality. Certainly not in the United States. And, you know, the fact that, you know, when you walk around with a suit on, you get treated differently than you walk around without a suit on if you're of color. But even if you're of color, whether you have a suit on or not, you get treated differently than if you're white. So all of those factors play in to society's views on people. And we've not done enough work on the impact of discrimination, stigma on biological functions that, frankly, I think at the end of the day probably explain even more of those inequities that we think we're correcting for, because we're not correcting for all of them.
Carol, I thought I could.
You know, I also think the
please go right ahead.
The disciplinary, or not disciplinary, the diversity of our leadership is important. And the example is the community health centers that were made and developed to have community people on their boards. So just to, as an example of how part of.
And on that note that Elena is pointing to, and building on what George just noted, when I was in federal government and these standards continue, the national standards for culturally and linguistically appropriate services in health and healthcare that the Office of Minority Health promulgated really to serve as a blueprint for health, public health and healthcare organizations. In enhancing those standards that happened in 2013, one of the key standards that was added to those standards was governance and leadership, and the importance of diversity in governance and leadership, the importance of cultural competency in governance and leadership, because when you think about trying to actually evolve institutions and practices and policies, having that as a framework within governance and leadership is critically important. And we know, just as George has noted, it's one, certainly a reflection of the increasing diversity of the population, of our US population, but it's also, it breeds excellence. It's excellence and innovation. And so when you have that at all levels of the organization or any type of entity, inclusive of governance and leadership, that's also an important way to actually address health disparities and advance health equity and improve quality.
You know, you're bringing up, I think, an issue that we in the private sector struggle with a bit, which is how is it that we begin to integrate issues of health equity in all that we do in our commercial efforts? And what I mean by that is that typically someone will say, well, maybe there's some unaddressed segment of the population that needs to be addressed for a for-profit effort. But I think that's not the way to look at it. I think the question is, how do we start to address the fact that many products and services that we create are—
That's been well shown to work is put together multidisciplinary teams across sectors. So the business community, the faith community, the health community, Chamber of Commerce is sitting at the table, the education community sitting at the table, and decide they're going to solve a problem and work in a collaborative way to solve that problem, putting both private sector and government resources into the pot, and then get the data and measure the outcomes on what we do. And then once we fix that problem, move on to the next one. That's how we're going to get there.
And I would add the importance of the sustainability of that, because all too often, we see there may be an investment for a brief period of time, and then that goes away. And we see that even, for example, with these public health emergencies, that there's this bolus of funding, the emergency funding that comes to support a specific emergency. And once the emergency ends, then it reverts back to either funding is cut or we go back to levels that really are insufficient. And we see that nationally, we see that locally as it relates to even the public health infrastructure to be able to actually help support communities to be healthy and thriving communities. And then similarly, with regards to the investment and supports for organizations that already exist in communities. There's been such a longstanding disinvestment in communities, and to the point about saying, are we truly just giving them a program, or are we actually investing in communities, allowing communities themselves to really drive the agenda? And there's been a longstanding marginalization and disinvestment of many communities of color and low-income communities that makes, all of these systems, whether it's in education or housing, economic opportunity, so challenging and difficult. And so it needs to be sustainable and sustained. It should be long-term and really at a level that we would recognize for any community to really have the opportunity to thrive. The business case for this, as far as advancing equity for the nation, is there. And there have been foundations and others like the Kellogg Foundation and PolicyLink that have all talked about the business case for doing this from the private sector's vantage point. But I'm agreeing with Georges that it has to be all sectors coming together and really saying we all have to invest in this and really not do this as a short-term 2 or 3 year commitment, but really this is long-term and sustained.
Excellent. So I know that we have some questions that have been chatted. Carol, are there some that you'd like to highlight right now to ask our panelists?
I think that Karen had answered the first one earlier, and I know that we've got a second one here as well. And then I love your idea of everyone closing with like what are the 3, boldest things that we can be doing that we can have as our follow-up catalyzing outcomes from this today. But the second question that came in from Chris Crayley is, Chris works near the Navajo Nation, where there's a significant number of communities and families without running water and electricity. So the idea of frequent hand washing is a challenge in this pandemic. What do we do to address the needs of rural communities as well as the urban communities? And we really haven't, in the last hour, talked so much about the very specific needs in the rural areas, especially those really isolated.
Well, this is Georges again. There's an interesting report from the Bipartisan Policy Center that looked at the healthcare needs for rural communities. And I know that there's a real effort in our nation to make sure that there's universal access to safe, affordable water in all communities, including rural communities. And so I think for us, many folks will stay tuned on that, because I think that will be an effort over the next couple of years to try to make sure that that actually happens. Now, the challenge of dealing with the Native American communities is are the treaty issues that have to be addressed as part of that, recognizing those communities are self-governing. But obviously the first thing we need to do is pay up what we have promised to pay up to start with. And because we have not adequately paid what we said we were going to pay as a nation to those communities under treaty.
I will say it's our mission today. We should have had a Native health leader on this, and we will definitely be doing that for November, and it's Indigenous Peoples Month in November that we'll be honoring, as well as veterans. So our apologies for that oversight, Chris, and thanks.
Yeah, this conversation has been so rich, right? But it feels like it's just the tip of the iceberg. And to that point, we've said we want to, bring together a series of conversations, because it's difficult to get it all in, of course, in 1 or 2 sessions. But I would like to end with, and going around to each of our panelists, again, we can do, Pierre, if you think in alphabetical order, the 3 top solutions that lots of conversation today, but those 3 top solutions and how we would be able to execute on those in our closing statements. So we'll start with Dr. Benjamin. Actually, let's go the other way. Since we started in alphabetical, we'll go the other way. Sam.
Yeah. So I think, 3 things for me is, first, data is important, right? If you don't measure, you don't know. I think there's a critical piece of making sure that we get publicly available data so that we can mine and truly develop the best of initiatives to deploy. Because today, I think there's some people anecdotally who know what's happening, but data brings transparency, which we've seen with COVID reporting. I think the second thing for me is truly partnering with faith-based organizations in the local communities. I don't think we've tapped into that. And it's, Black folks give more as a % of their income to their churches, as an example, more than any group. So it still remains a core piece of who groups are. So whether it's, your church, your mosque, your synagogue, you name it, that could be a part of economic mobility that we should really tap into. And I think the final piece for me is organizations helping in adjacencies. And by what I mean is, how do you pick corporations to deliver their capabilities, what they're good at, to help their local communities, right? So in the cases of, you could have Walmart using their parking lots for testing. Nobody would have thought about that, right? So how can, McKinsey as an example, we're good at developing leadership training, and we just about 3 months ago made a commitment to offer leadership training for all Black Americans, executives in the country. So if organizations leverage what they're good at doing and make that available for public good, I think we can get to some major improvements.
Excellent. Thank you, Sam. Thank you so much. Dr. Rios?
I think I would echo what Sam said, but I think I'd add a focus on the public health and prevention side of the dollars in this country, and to focus on reallocating the healthcare dollars at all levels. I'll just say acute, nursing home, hospitals, all these major institutions. I think if we spent some of their money on public health infrastructure development that connects to the local level, and I think that the healthcare workforce needs to be retrained to be a workforce of public health. So I'll give you an example. Some of our doctors, Latino doctors in the Los Angeles area, they had to close their practices because of COVID at the beginning. But what they did is they had the phone numbers and the data to call and connect to their elderly patients who had diabetes, heart disease. And they called them and had staff use that connection and then work with the public health departments. This was in East Los Angeles and Pasadena. There's a LA County Health Department, but there's also a Pasadena Health Department, and they were able to connect. And I think we have to do that through public health. And then the other thing is, I think the workforce needs better training on cultural competence and racial, ethnic, social determinants of health. And by having our trainees, public health, medicine, nursing, dentistry, train in the communities, which never happens. I mean, we have some programs here or there. I think there needs to be a mandate to have that public service that we've all thought about. National Health Service Corps as an example, but even then, that's just a revolving door. So I think we need to have a better attempt at redesigning the workforce to care for the most vulnerable in our communities, rural and inner city. I'll leave it at that.
Thank you. Dr. Karen McNeil-Miller.
Thank you. I would end with a few things as well to say that particularly after the death of Mr. Floyd, there were thousands of organizations that put out these most eloquent statements of solidarity and what they were going to do in their organization. So I would say if only half of those organizations did only half of what they promised to do, that alone would be transformational. So if you are in power and you made one of those commitments, keep the commitment. So that would be one thing. Secondly, I would also continue to say, put capital into the community for people to make their own decisions of how to best advance their neighborhood. Then lastly, I think it's more of a don't than a do. Don't expect or put the burden on Black folks to solve racism. I don't know why we expect the oppressed to explain oppression to the oppressor. So it's how do majority-led organizations really take an active role and the predominant role in dismantling racism and not expecting it to be on the backs of Black folks.
Amen. Dr. Nadine Gracia.
Yes, thank you. These are all great insights and comments. I would, and I may be echoing what some others have said. I agree on one, investing in prevention. As a nation, we spend annually about $3.5 trillion in health, but less than 3% of that is for public health and prevention. So we need to invest in prevention and have that be sustained and increased so that, again, we can really move upstream and trying to prevent what are preventable conditions and create conditions for everyone to thrive and be healthy. Two, I would say is really to model and actually implement and do what we're saying as far as breaking down these silos and working in a truly multi-sectoral, multidisciplinary approach at all levels, from the national to the local levels, so that we can really see transformative change because so many of these issues are interconnected. And then I would certainly also advocate for the need to truly invest and bring capital into communities that have been marginalized, disenfranchised. It's for them to really have the opportunity that is equitable, and so that we can achieve equity as a nation and achieve equity as a nation and also reach our full potential as a nation. The vitality of the nation really depends on everyone having that fairness and justice.
Thank you. Dr. Benjamin.
Sure. I think we ought to make sure that we all listen more to these communities and talk less. And of course, when we do talk, walk the talk. Secondly, all communities have strengths, and we should identify those strengths and build on those strengths of those communities. And then finally, we should think about the investment in those communities as something that's a sustainable investment. that will have enormous return. We ought to see those communities as customers that we are investing in for the future, and not simply dump a little bit of money in there, tell them they have to build themselves up from their bootstraps, because that isn't the way most things are done in our country, even though we believe that we often talk that way. That's not the way real capital investment or our society really has developed, if we really look at it.
Excellent. I'm going to give one of my action items, and then I'm going to turn it over to my co-moderator for his closing remarks. And to close this out, he's really helped me tremendously. I'm trying to juggle my day job here. But you know, for me, it is closing the education gap. What I am dumbfounded about is that young children from the community from which I am from, Inkster, Michigan, and the amount of funds that are allocated to that student every month as it compares to a more affluent area, which is only about 20 minutes away, Birmingham, Michigan. That perpetuates the cyclical issue. As soon as I was able to go to college, I had a lot of catching up to do. But as soon as I was able to be at the table, I caught up quickly and was able to, ace medical school. So as soon as you give me the opportunity, and many children who look just like me in the communities from which I'm from, as soon as you give me the opportunity, trust me, I will be able to catch up, and I will be able to ensure, because of how I was raised, that I give back. And so I would actually want this committee, this group of thought leaders, to hold our governments responsible on a state level for neutralizing the amount of money that is being funded and allocated per student, and that it should not matter on the zip code at all. Every student should be able to receive the same amount of funding for education, no matter what zip code for that particular state. I know it sounds bold, but it's been said over and over again. It's going to be very expensive, but we are worth it. And so closing that education gap is the one deliverable that I would like to see.
That's fantastic, Monique, and what a great place to really close this and bring this incredible session to a close. There were a few themes that seem to be very persistent across all the voices today in terms of allocation of capital to low resource settings, a real shift towards preventive care, and also being attentive to the data that continues to make the case for these health inequities and how we can address them specifically. But I thought one theme that was really spoken to by essentially every member of this panel was really breaking down the silos that often exist among the different sectors. And I would really encourage all of us, whether you're private sector in healthcare, more on the policy side or in education, to be willing to sort of reach out, if you will, across sector lines to try to come up with novel solutions. So I think it was Sam said earlier on, we've admired many of these differences and equities in the past, as it were. Let's go beyond that admiration by reaching across these different sectoral borders and come up with novel and impressive solutions in the future. So to all of our panelists, I'm very grateful for you having joined us today. There's a series of questions that have been asked here in the chat room, so we'll likely disseminate them to you as well afterwards. So once again, I really appreciate the insight, extremely helpful. Back over to you.
And I want to thank all of you as well, from all of us at Global Minded, and really want to say in my closing thoughts is just how do we, from now until next month and every month, really raise these issues with people who are in those places of power, who don't know these things that we've spent the last hour talking about. And even though it seems so crystal clear to us, so many people are still so in the dark about the realities that we face and we know are really urgent to the nation and the world at this time. So, I think for that, even Pierre, for you, or Sam, for you, to think about, folks this year, the virtual World Economic Forum, how could possibly the voices of these incredible people at this panel be part of that this year, where there's very few women and people of color amidst those folks that have so much control over the flow of money and outcomes to resource the things we've just spent the last, more than an hour talking about? And where are other places, in addition to policies, where we need to be able to really be there very boldly to raise these things with people who need to be A, informed, and B, held accountable for the kinds of advancements that they say they want, to make sure that they boldly really do level the playing field for these populations. So I want to thank all of you, but especially Monique Butler for just putting the stake in the ground to get this team formed, the equity team, and Pierre for stepping up to really help her, and for all of you for making the time for this, and for those of you who attended, those of you who are watching us later via the recorded sessions on the YouTube channel. We're delighted you made this a priority, and please write to us if you want to be connected to future events. We hope we'll see you here every month, and that you'll share with us your ideas of what this health equity team needs to be solving for you and the people in your health and diverse pipelines that you're serving. So thanks to all of you, and take really good care. It's been just an honor to meet all of you and to work with you on this, and to really launch these efforts and know that we're going to have deliverables that are going to be attached to them. So thanks to all of you for joining today.
Thank you all. Thank you so much, panelists.
Thank you.
And I will